Good evening to all my dear students. Most of the time, the questions that are asked from this subject are straightforward questions. Now, like any exams, when you have to answer those straightforward questions that are called sitter questions, you will have to be very thorough with certain pages of that chapter or certain portions of that chapter. And in all of these, brain death, organ donation, and ethics, you will find very voluminous books. And if you want to go through those books, it will be very difficult, all the more. But there are certain areas from which the questions are picked up. And if you scan through those areas before your exams, I think you will not miss the sitter questions. And the the question paper setters are very careful because this brain death, there are certain complex issues involved in this, and the legislation varies from country to country. And although a lot of clarity has been achieved as of today, but still there are a lot of gray areas and there are a lot of differences in opinion. So those areas which have differences opinion are usually avoided for the sake of the exam. So that is one good thing about this. So we will cover in brief brain death, organ donation, and ethics. Now, ethics is particularly a broad chapter because it involves both ethics in relation to the ICU practice including organ donation, of course, and as well as ethics beyond the ICU practice, including ethics in research. So questions can be picked up from either of the areas. So certain areas of these are if you can remember it, then probably it will be useful in the sense. Let us start with brain death. Now, this is the WHO definition. And this definition has been modified several times because the first brain death, which was technically considered to be brain death, was first tasked in the year 1968. So from 1968 to 2024, 50 plus years, 55, 56 years. So a lot of changes have crept in, some surreptitiously and some consciously. And those changes have been accepted or rejected at different times based upon the reasons, both pros and cons. And what stands today is this WHO, the Global Glossary of Terms and Definitions on Donation and Transplantation. And here the brainstem death takes into consideration the issues which are related to transplantation. And therefore, this is the most acceptable definition that we have today. And you have to remember each and every line because some of these lines may get twisted and questions may be framed just to confuse you, to mislead you into answering the wrong option. So irreversible cessation of cerebral and brainstem function characterized by absence of electrical activity in the brain, blood flow to the brain, and brain function as determined by clinical assessment of responses. A brainstem dead person is dead, although his or her cardiopulmonary function may be artificially maintained for some time. Now, to note here is that the clinical assessment of responses. If you can underline this line, then you will find a lot of clues and a lot of questions can actually emanate from this phrase. So if from this phase, you can emanate what are the clinical steps of clinical assessment of responses, what do you mean by clinical responses, when is a patient considered to be in a coma, When do a patient is considered to have absent brainstem reflexes, etc., etc. So this clinical assessment of responses is something one needs to know, and one needs to know a little bit about the physiology pertaining to the coma unconsciousness and assessment of responses in this context, because all patients can with brain dysfunction can have some kind of unresponsiveness, but all unresponsiveness will not account for coma or not qualify as a coma. So brain death, if you can see on your left, is a complete, permanent and complete loss of all brain function in both cerebrum and brainstem. So note that these areas of the brain are distinct, one controlling the higher functions and another controlling the vital centers. So in cerebrum is language, responsible for language, memory, emotion, voluntary movement, and all the cognitive abilities. Brainstem controls breathing, heart rate, blood pressure, level of consciousness, etc. So loss of blood flow to the brain due to heart attack, stroke, bleeding in the brain. So most commonly the traumatic brain injury, the cardiopulmonary bypass, the cardiac arrest. These are common causes which are accounted for brain death, although brain death can occur after many more causes, including poisoning, etc. But whenever we consider diagnosis of brain death, these three conditions must be confirmed to declare brain death. One is that the patient is in persistent coma. There is no eye, verbal, or movement response to painful stimulus. Patient has no brainstem reflexes, that is, no eye response to light or cuff response to throat suction. And three, patient cannot breathe without assistance, that is, no breathing for 10 minutes without mechanical ventilation. Now, each of this can be elaborated at length. We will touch upon each of this, but broadly speaking, when you understand brain death and understand the definition in context to or in accepting all those things which are written on the box on the left side in with this image, then probably you won't miss anything. Now, as I said, whenever we diagnose from brain death to qualifying for organ transplant, that involves a series or sequence of steps. So some of the steps involve gross clinical assessment or gross clinical tasks, whereas some involve both clinical and technical tasks. So you have to understand each and every step and the role of an intensivist in each one of those steps as it moves on to the next step. Because if the first task is not complete, you cannot move on to the second. So you start with the neurological tests. When you confirm that this is an irreversible brain damage, the treatment futility or enforced prognosis has to be proven, because if the treatment futility is not proven, you can't go further. And there has to be consensus between the treating physician, the intensivists, the neurologist, etc. Next, identified as a medical suitable for organ donation. Suitability for organ donation is based upon a lot of complex criteria, and you have to know them. I will touch upon them in the subsequent slide. Consultation of the donor register, because where every place in the world they have a donor registry, so that the candidate who is eligible to accept the organ is identified on the basis of that register. And only once the patient is registered is refusal, then you go to the next. Approach of the family members. If the family members of the brain dead patient needs to be approached, even if the patient has given his or her consent earlier, and there can be family refusal, of course. Of course, there are two different aspects, opt-in and opt-out donation. We're not going into this because that is technical and that varies from country to country, and therefore not too many questions you can expect from this opt-in or opt-out, because there are differences and debate among the legislatures upon this too. Next is the consent for organ donation. When the brain death organ is determined, if the brain death is not determined, that is not heart-beating donor, then we are identified, because there are two types of donors you can identify. So one is the beating heart and another is the non-beating heart, so NHB donor. Once the brainstem death is determined, then the heart-beating organ donor is identified. So these are all the steps which follow one after another, and only when the consent for organ donation has been accepted. You would go for all brainstem reflexes, EEG, apnea test, etc., as the case may be. Now, there are certain vital signs and general criteria which needs to be followed. One, the core temperature has to be maintained above 36 degrees centigrade. So, if active warming should be followed. Systolic blood pressure should be more than 100 with or without pressors. Absence of drugs that could simulate brain death, like the neuromuscular blocking agents, drug intoxication. We have to check the blood alcohol concentration. That should be less than 0.08% and so on. Next is absence of brainstem reflexes, which includes fixed pupils, absent corneal reflex, absent oculovestibular reflex, that is the caloric test, absent oculocephalic reflex, that is the doll's eye, absent gag and absent cuff reflex. There should be absence of any cerebrally mediated response to auditory and tactile noxious stimulation peripherally and in the cranium. And apnea confirmed with the apnea challenge test, with no respirations with PCO2 of more than 60 millimeter of mercury. Now, if you go through it, you can very clearly understand that each of those reflexes, also that brainstem reflexes, you have to know it, at least the basic methodologies, because there can be some questions related to this. Let us we look into a few questions, some A-type questions. A 30-year man who had traumatic brain injury was declared brain dead. He's a potential organ donor and he progressed to shock. What would be your next appropriate step? The options are: administer methylprednisolone. It is associated with increased organ retrieval and it should be given as soon as possible. 2. Myocardial ischemia is a common complication. All donors require angiography. 3. Noradrenaline is the vasopressor of choice. It increases the vascular tone. And 4 or D, triiodothyronine, that is T3, should be given immediately administered in brainstem to prevent vasoplegic shock. So can anybody volunteer? You can unmute yourself and give your answer if you wish to. So Fatih Ischali has given an option of C. Well, the answer is A. Administer methylprednisolone because it is associated with increased organ retrieval and it should be given as long as possible. Now, vasopressin may reduce catecholamine requirements, but it is the vasopressor of choice. And MI is not common complication, but needed to be considered in patients having risk factors of MI and screening echo suggesting regional wall motion abnormalities. Not all donors will require angiography. It may be considered in those with HER donors. The iodothyronine, that is T3, can be considered to reverse hemodynamic stability, but not as a prophylaxis. And the corticope study showed no beneficial effect on graft recovery except during reducing the need of vasopressors in donors receiving hydrocortisone. But observational studies have demonstrated improved hemodynamic and status and oxygenation. So despite this, steroids are widely utilized tool for organ donor resuscitation, and therefore the answer should be methylprednisolone after excluding the choices B, C, and D. Another question: you are an attending physician in an ICU. A 45-year-old female who is a potential organ donor was brought to your ICU for hemodynamic monitoring and optimization. Which is a false statement? Which is a false statement? A. Initiate sedation to stabilize blood pressure and prevent shivering of the patient. B. Lung protective ventilation strategy with a tidal volume of 6 to 8 mL per kg with optimal PEEP and minimum FiO2. C. Tracheal cuff pressure to be maintained at 25 centimeter of water and head of the bed elevated to reduce the risk of aspiration. And D. If vasopressor drugs require vasopressin 0.4 to 2.4 units per hour can be used to reduce the catecholamine requirements. So which of the statement is false? Any takers? Well, someone has answered D. D is not false, in fact, because we have...
I think A is the false one.
Absolutely, you are correct. So initiate sedation to stabilize BP and prevent shivering of the patient is the false statement. And we have to stop unnecessary drugs, particularly the sedatives. Reduce heat loss and actively warm if necessary to maintain the core temperature above 35 degrees. 36 to be precise. Use lung protective ventilation, tidal volume of 6 to 8 ml per kg with an optimal PEEP to allow minimum FiO2. Maintain tracheal pressure cuff at 25 centimeter of water and nurse with head of the bed elevated to reduce the risk of aspiration. If vasopressor drugs are required, vasopressin 0.4 to 2.4 units per hour may reduce catecholamine requirements. High doses of catecholamines like norepinephrine in excess of 0.05 mg per kg per minute should be avoided. If urine output is more than 4 mils per kg, 4 mils per kg per hour, then consideration of diabetes insipidus should be made and treated with vasopressin infusions or arginine vasopressin, that is desmopressin, DDAVP. So these are the contexts which I am discussing in the areas surrounding this question, which also you should know, because these parts, these are very sensitive, because from where questions can be framed. Coming to another E-type question, which among this is not an essential component of brain death? A, irreversible coma due to a proximate cause. B, absence of brainstem reflexes. C, irreversible apnea. And D, absence of spinal reflexes. Any takers? Well, someone has.
D.
If everyone is saying D, then the correct answer is D. So brainstem is equivalent to death despite the maintenance of heartbeat and spinal cord function. So the diagnosis demands proof of irreversible loss of consciousness, brainstem reflexes, and the ability to breathe. So spinal reflexes, absence of spinal reflexes is not an essential component. So it's a simple and questions, but that also puts into test your knowledge about the definition. Sometimes many people get confused with brainstem reflexes and spinal reflexes and think that spinal reflexes are always a part of brainstem reflexes. It is not so. So this is one area from where questions are picked up most often. We should know it, how to perform the apnea test, or what are the preconditions, criteria, and the steps of doing the apnea test. So vasopressor should be adjusted to maintain a systolic BP of more than 100 millimeters mercury. Pre-oxygenation is given for at least 10 minutes with an FiO2 of 100% and PO2 more than 200. Reduce the ventilatory frequency to 10 breaths per minute. Reduce PEEP to 5 centimeter of water. If the saturation remains or the SpO2 remains more than 95%, obtain baseline blood gases. Disconnect the patient from the ventilator and preserve oxygen with O2 delivered through the insufflation tubing given at 100% FiO2 of 6 liters per minute near the level of the carina through the endotracheal tube. Look for respiratory movements for 8 to 10 minutes. Repeat blood gases approximately 8 minutes if no respiratory drive is observed, and if no respiratory movements are observed and PCO2 rises more than 60 millimeter mercury, or if it increases by 20 millimeter of mercury over the baseline, then the apnea test result is positive. So this is, except of course in COPD where it is very high. So there you can't comment on this. Now, if this above list is completed and coma, present absence of brainstem reflexes and a positive apnea test are present, then the diagnosis of brainstem death can be made. Now, this is another area from where questions may be picked up. When should we abort the apnea test? In case of any respiratory movement where abdominal or chest excursions or a brief gasp, whatever it may be, exists, the systolic blood pressure decreases to less than 90 millimeter of mercury, and oxygen saturation is less than 85% for more than 30 seconds. If so, the procedure has to be retried with a TPIS, maintaining a CPAP of 10 centimeter of water and an administration of oxygen O2 at 12 liters per minute. So these are also some of the other important informations surrounding apnea test you need to know. Coming to the next question, another A-type questions. You are a medical officer treating the patient and a team member who is supposed to certify brain death. Identify the false statement. Treating doctors should not be part of the brain death certification team. B, etiology of coma or irreversible brain damage should be known. C, an observation period greater than 4 times the half-life of the pharmacological drug should be used, the drug that confounds assessment. And according to the THOTA Act, that is, of course, pertains to Indian context, 1994, 2011, 2014, that is the amendments, and the THOTA rules of 1995 are the only legislative acts where brain death certification procedures have been laid down. So I think it's an easy question, so you will be able to answer it without much difficulty. You have to identify the false statement. Let me check what majority have given. Someone has written A. Roshin James has also written A. So if two of you are written A, so obviously I think you are right, both of you. So treating doctor should not be a part of the brain certification team. This is the false statement because treating doctor can be a part of the brain death certification team, and it is suggested to wait for greater than four times the half-life of the confounding pharmacological agent before proceeding to assess the brainstem functions in case the patient has been suspected to be administered to have with one. And THOTA Act is the only legislative act in India where in brain death certification procedures are laid down. So this is a easy question, but good that you got it correctly. Now, there are certain areas from which there are recommendations from most of the societies, particularly the American Association of Neurology. You should go through the guidelines or recommendations because that is followed in most parts of the world, and that is a very comprehensive, and that raises many issues which are ignored in other guidelines. So that is the standard which is followed by the transplants centers most of the time. So if you follow the what are the general management, central line insertion and monitoring, arterial line insertion and monitoring, nasogastric tube insertion, Foley's catheter insertion, care lines, continued side to side bed positioning, warming blankets, maintaining pneumatic compression device, eye protection, frequent airway suctioning, ulcer prophylaxis, broad spectrum antivirus. So these are all part of the general management in any brain dead patients who is likely to be posted for transplant. Monitoring vital signs check every 1 hour, urine output check every hour, ABG with continuous monitoring, ABG analysis, arterial blood pressure continuous monitoring, and ABG analysis every 6 hours, body temperature check every. And there are certain therapeutic targets. It is not possible to remember all, but at least you should remember the ones which I am mentioning here. I have picked up the ones from that 76-page document, that what should be the target of the mean arterial pressure, hemoglobin, sodium, potassium, central venous or mixed venous saturation, arterial blood gases, lactate, PCO2, blood sugar, what should be the hourly urine output, and central body temperature, because many of this can be used as an option in identify the false or all are true except, or which one is true, like that. Now coming to the next question, with respect to the non-transplant organ retrieval centers, NTORC, identify a false statement. A, they are permitted to certify brain death. B, any director of health service registered hospitals having a facility of an OT and ICU has been defined as NTORC, that is non-transplant organ retrieval centers, that is from where organs can be retrieved and shifted elsewhere for transplant, perform organ retrieval, or also permitted to perform transplantation if required. Which is false? Again, a very simple question. You will get the answer easily without much thinking. They are not permitted to perform transplantation under any circumstance. So this you have to keep in mind, because these centers are under the Directorate of Health Services registered hospitals, which are designated or permitted to certify brain death and perform retrieval, not transplantation. Come on, another question. A 56-year-old man who suffered hypoxic brain injury and was declared brain dead on the 7th day of the ICU. The family requested voluntarily for organ donation. He was evaluated further and CMV antibodies were found to be positive, IgG. He had childhood history of lymphoma and had completed the treatment. He had purulent tracheal aspirate and a fever of 101 degree Fahrenheit. His bowel cultures yielded Acinetobacter baumannii sensitive to meropenem. He was initiated on culture-based antibiotics. PF ratio is 340. Which of the following statements is correct or true? A, His lungs were not suitable for transplantation due to infection. As I said, mentioned infection due to Acinetobacter. Positive CMV serology in the donor will adversely affect on patient and graft survival. C. Presence of any malignancy is a contraindication for transplant. And D. After appropriate antibiotic therapy, organ retrieval is possible even in a septic donor. Which of the statements is correct?
I think D is the one. D.
D. So someone is saying D, someone was saying B. So let us see, the answer is, you are correct, it is D. The true statement is after appropriate antibiotic therapy, organ retrieval is possible even in a septic donor. So positive CMV, HSV, EV serology is not a contraindication to donation, and with chemoprophylaxis for the outcomes are similar. Tumors with low-grade malignancy or localized neoplasms are also not contraindications. After appropriate antibiotic therapy, organ retrieval is possible even in septic donor who are hemodynamically stable or tapering vasopressor therapy. Even lung donation is possible with adequate antibiotic therapy. So this is an important area, or it is a, if you don't forget it, you will be able to answer most questions which may come on this on the basis of this concept. This concept is important. The questions can be any. The questions can be framed as per the question paper setter's mind. So K-type question: indicate true false regarding persistent vegetative and brainstem death. Persistent vegetative state result from damage to cerebral cortex. In brainstem death, damage to ascending reticular activating system leads to a state of persistent deep coma. Spontaneous respiration is absent in persistent vegetative state. Cranial nerve reflexes will be absent in persistent vegetative state. So true, false, you have to identify T, TFF, TF, TF, etc. So let me see what someone has made TTFF. Anybody else making any attempt? No. So you are correct. It is TTFF. Persistent vegetative states result from damage to cerebral cortex, and in brainstem death, damage to RAS leads to a state of persistent deep coma. Both these are true, and the brainstem death is secondary to irreversible brain damage, and hence both consciousness and cranial nerves are absent. That's why those are false. Another K-type, again, it is true, false. What is regarding the apnea test? Apnea test is mandatory to establish brain death. Aim is to test for hypoxic respiratory drive. Pre-existing respiratory illness like COPD is a contraindication for performing apnea test, and respiratory-like movements such as shoulder elevation and action, back arching, intercostal expansion without significant can be observed during apnea test. Anybody attempting? No? So here the answer is triple FT. So you had written for all false, but the last one is correct because respiratory like movements, if you this can be observed. So these are called the Lazarus reflex, respiratory like movements, and especially when the patient becomes hypoxic, they can be observed during apnea test. Otherwise, apnea test is not mandatory but desirable to establish brain death, and in severe cases like severe lung injury where hypoxemia it is not feasible. I have already mentioned you in the earlier, and it tests the hypercapnic respiratory drive, not the hypoxic drive. So that was the reason why that statement was false. You got it correct. So good. And apnea test can be performed in most cases of COPD. The target elevation of COPD will be more than 20 millimeter above the baseline. So these are some of the medication protocols, and you should know it to, because these can be among the choices in the true, false, in K-type questions, that what are the agents in patients with hypertension, hypotension, the choice of fluids, because in fluids we avoid synthetic starch, we avoid excess volume, balanced crystalloids should be used. vasopressors, norepinephrine 20 milligram in 5% dextrose, 500 ml. So these are the standard corrections, which are the medication protocols that one need to know. And one important thing is to how to start regular insulin in and maintain sugar. Regular insulin 100 million units in 100 ml mix, that is 1 unit per ml, and you start at 1 unit per hour, maintain between 200 to 300. If it goes up to 300 to 400, you increase it to 2 units per hour. If it goes above 400, you increase the regular insulin dose to 3 units per hour. So this is the initial starting dose, followed by a maintenance of dose, that if it is persisting between 200 to 300, after increasing, you again add 1 units per hour. 300 to 400, make it 2. 400 to 500, make it 3. So likewise, you will have to keep the blood glucose control. If the patient is having hypoglycemia, then you have to administer 50% dextrose, 10 ml IV infusion, and notify. If it is less than 50% dextrose, 20 ml IV first, and then notify. Steroid replacement, methylprednisolone 200 milligram in 0.9% saline, 100 ml IV infusion at the rate of 4 ml per hour. Just try to remember and calculate the dose to the extent possible, so that you don't go too much away, because some differences in dose have been noted. The ones I am telling you is widely accepted because they are from the American Association of Neurology. Most societies who have for guidelines follow it, including our Indian NOTO. But you will have to know at least the infusion rate, initial starting dose in most of the cases. So other agents that are used are mucolytics, anti-ulcer agents, antimicrobials, and so forth. So these are some of the important types. Now, coming to the ancillary tests, some questions may be picked up from the ancillary tests. If you know the indications of angiography, etc., then you will be able to answer. Just go through it in trying to understand that when they are become essential, particularly when apnea test cannot be performed. So indicate true false regarding ancillary tests for determining brain death. Choices are: A, ancillary tests can be used as alternative to clinical neurological examination. B, lack of TCD, transcranial Doppler signals, cannot be interpreted as confirmatory of brain death. C, in conventional CT angiography of brain death patient, there will be absent arterial blood flow in both external carotid and internal carotids. And D, EEG can be isoelectric in patients with preserved brainstem reflexes. So any attempt? Let me check the response. So someone has put true, false, false, true, TFFT. So it is actually FTFT. So ancillary tests can be used as an alternative to clinical neurological examination. We clearly see that confirmatory tests are optional in most guidelines and reserved where clinical diagnosis, including, cannot be completed or doubtful. It is not that confirmatory tests are mandatory. They are optional in most guidelines. Lack of transcranial Doppler signals cannot be interpreted as confirmatory because 10% of patients may not have a temporal insonation windows. So in that, those patients will be missed. C, EEG does not demonstrate brainstem activity. It can be isoelectric in patients with brainstem reflexes who are clearly not brain dead. And brain death confirmation by demonstrating the absence of intracerebral filling at the level of the carotid bifurcation of circle of Willis, and external carotid circulation is patent. The filling of the superior sagittal sinus may be delayed. So these are the findings which clearly found to be associated with, which can indicate the brain death. Another K-type question: indicate true or false statement regarding donation after cardiac death. A, warm ischemia time is a time lag between treatment withdrawal and cold perfusion. B, DCD kidneys grafts were far inferior to that of donation after brain death. That is, donation after cardiac death grafts were far inferior to those donation after brain death. Warm ischemia time is a key determinant to successful transplant outcome. And donation after cardiac death heart grafts are difficult to use because of unavoidable weight. So what is warm ischemia time? You can understand the full form. So which of these are true and which is false? You may take a little time because this is slightly difficult in comparison to the easier ones. Well, nobody attending. So the correct answer is true, false, false, true. So warm ischemia time is a time lag between treatment withdrawal and cold perfusion. That is correct. DCD kidneys were far inferior to that donation after brain death. That is after DVD. This is false. Warm ischemia time is the key determinant to successful transplant outcome. And DCD grafts were difficult to use because of unavoidable warm ischemia time. So DCD and DVD renal grafts examined for 10 years showed equivalent survival. So it cannot be conferred with certainty that one is superior or another is inferior over the other. Let us go through this K-type question. Again, indicate true, false regarding contraindications for organ donation. A, donor infected with HIV was considered as an absolute contraindication to organ donation. B, presence of any CNS tumor is an absolute contraindication to organ donation. C, liver or kidneys from HCV positive donors may be transplanted into HCV carriers. And D, the donation of organs is not a contraindication for donors with past history of melanomas. Melanomas, as you know, is a form of skin cancer on the melanocytes. So again, you have to answer true, false in. One answer has come and it is false, false, true, false. So again, it is first part only you have made, rest you are correct. So donor infected with HIV was considered an absolute contraindication to organ donation. This is true. Presence of any CNS tumor is an absolute contraindication is false. Liver or kidneys from HCV donors may be transplanted into HCV carriers is true. And the donation of organs is not a contraindicated for donors with this is also false. Now you have to remember that infection with HIV was considered an absolute contraindication until very recently because a case series of transplantation showed satisfactory outcome at 1 and 5 year follow-up similar to that of the other populations. So although this process approach was suggested as an option, so the long-term outcomes of these patients are still not known. So therefore we consider it as true, although people may argue upon it, debate upon it, but now it is almost foolproof. Now, donation in cases of tumors with low degree of malignancy or localized neoplasms is acceptable. That includes skin tumors like basal cell, squamous cell, CN, but not the melanomas. Carcinoma in situ, like cervical carcinoma in situ, primary CNS tumors according to the Council of Europe, the CE recommendations, that is metastasis outside the CNS are rare. Organs may be considered for donation. Benign meningioma, craniopharyngioma, acoustic neuroma, etc. So there are exceptions. You may not remember all the tumors, but you have to remember that there are exceptions, and otherwise in low-grade malignancy localized neoplasms, one can consider transplantation. Now, come on, answer this K-type question. Again, indicate true, false regarding pathophysiology of brain death. A, autonomic storm with hypertension, tachycardia is due to brainstem compression. B, bradycardia following brain death usually responds to atropine bolus. C, hypernatremia is associated with poor liver graft function. And D, TSH secretion ceases and thyroid hormone becomes depleted rapidly within 12 hours of brain death. You can take your time and answer because this requires a little bit of recapitulation. Someone has put true, false, true, true. So it is true, false, true, false. So last one you just got confused. Never mind, but it's a good attempt because sympathetic storm with hypertension, tachycardia is due to brainstem compression. If bradycardia develops, it is not of vagal origin. The vagus will be denervated and therefore this will not respond to atropine. Hypernatremia is to be avoided. It has been associated with poor liver graft function and the risk of graft is 3 times higher if the sodium is more than 155. And fourth, the TSH secretion ceases, but thyroid hormone becomes depleted only after 24 to 48 hours. So this is something you should be able have to remember because again, this is a particularly a tricky area, a prone area from where questions can be framed. Now, let us move on to ethics. We have discussed enough of brain death and organ donation. I think you have been able to grasp the concept and the areas from where questions are usually asked. And if you go through those areas and if you follow the American Association of Neurology guidelines and try to just get the gist out of those guidelines, they will be good enough. The information that you can gather will be good enough to answer all the seated questions from this part. Now, 4 pillars of medical ethics, you have to know that these are called autonomy, beneficence, non-maleficence, and justice. So these are all concepts because, and one can expect questions that include all except, and some new name can be added in absence of any one of this. So autonomy means respect for patient as an individual and respect the patient's decisions. Beneficence, do only good. Non-maleficence is opposite, that is do no bad. And justice, treat everyone equally within the law. So these 4 principles represent a framework for analyzing the best action which can be taken in a given situation. Coming on to the questions. Now, these are all concept-based questions in ethics, but if you can grasp the concept, you will be able to again answer any questions, because this part, the ethics part, this requires some form of analytical mind. So you have to apply your mind to see correctly or to see through the things when such a problem statement is given to you. Our patient has a serious illness and is about to undergo surgery. Just before anesthesia, she asked, "Doctor, will I be okay again?" To which I said, "Yes, of course." And even though I am not sure about the outcome, the surgery was later proven unsuccessful. Which of the following statement is regarded is true or false with regard to the medical ethics? So it's again a key type. So my action is in violation to the code of ethical conduct. B, my action is not a violation as it fulfills the consequential ideology. C, my action is not a violation as it is not written or recorded in the file. D, my action is not a violation as long as there is no complaint. So someone let me check which of the following statements. So you have to understand that consequentialism, that is an ethical ideology that states the morality of an action is dependent purely on its consequences. Now, this action is not a violation because it fulfills the consequential ideology, because the consequences of that act will determine what is there. So in this consequence, it is not a violation. So in respect to the medical ethics, so my action is in violation to the code of ethical conduct. So this is false. My action is not a violation as it fulfills the consequential ideology. This is also false. My action is not a violation as it's not recorded or written in the file. It is false. And my action is not a violation as long as, so obviously you can understand that there is, it does not fulfill that criteria B. So of course, A, C, and D are all false. Another question, you have a sum of money to either fund a very expensive treatment for one patient or a rare disease with a rare disease, or 5 patients with a very common and easy to treat disease. You choose to treat the patient with rare disease because he approaches you first. Which of the following statement is true or false regard to the medical ethics? I think you get.
सर पहली वाले का क्या आंसर था?
Yes, I have told na, this one, previous one.
Yes,
I
sir.
told you the answer B is correct, rest all are false. I had shown you, na? I had shown you. Yeah, this one.
Yeah.
My action is not a violation as it fulfills the consequential ideology. This is true. A, C, and D, you can well explain, are false. A is my action is in violation to the code of ethical conduct. This is false. My action is not a violation because it fulfills the consequential ideology. So this consequential ideology is what I have stated below. My action is not a violation as it is not written or recorded in the file. It is false. My action is not a violation as long as there is no complaint. This is also false. So the answer is false, true, false, false. Now it is clear absolutely.
Yes, sir. Yes, sir.
Any doubt? Great. Now, this is again, you have to consider that you have limited resources. And with this limited resources, you can treat one patient versus five patients. Now, the one patient, he is having a rare disease. The five patients are having common disease, easy to cure. You choose to treat the patient with rare disease. And the five patients whom we could have treated otherwise are bereft of that benefit of treatment. Now, what is true or false regarding your you have violated the utilitarian principle in ethics. You have not violated because easy to treat disease can recover on its own. You have not violated because there are no guidelines to follow. You have violated because consent was not obtained from the relatives of the patients with the common disease before treating. Any guesses? It is slightly difficult. So someone has written C, that you have not violated because there are no guidelines to follow. That you have violated actually the utilitarianism in ethics, because utilitarianism in ethics dictates that treating five patients is morally superior as greater overall benefit is achieved. So you have violated, that is true. You have not violated because easy to treat disease can be recovered on its own. This is false. You have not violated because there are no guidelines to follow. This is also false. You have violated because consent was not obtained from the relatives of the patients with common disease before treating the patient with rare disease. This is also false. So it is true, false, false, false. So again, this consequentialism, utilitarianism, these are concepts. So once you understand the concepts, which will barely take few minutes, once you go through any of the ethics books, then there will be no problem at all. One, again, if a terminally ill patient asks if they will be okay after surgery, they are unlikely to survive. A dash approach would suggest you don't lie just to comfort them. That's because, according to this concept, lying isn't morally acceptable because it's our obligation not to lie, no matter what the consequences are. Which concept I am talking about? You have heard about the consequentialism in the first question. You have heard about utilitarianism in the second question. And the third here, it is the deontology. So deontology means that the morality of an action is based on whether you follow the rules rather than the consequence of what happens. So this is in direct contrast with the consequentialism. Consequentialism, you are allowed to lie. You are allowed to tell a patient that you will become all right, even if you know that the patient is going to die, considering that your lying will have some benefit on the patient, will reduce his worries, make things comfortable, enable the surgeon to undergo surgery better without much distress, etc., etc. So that principle is consequentialism, because your consequences determine the ethical principles that you follow. The deontology is just the opposite. It means that whatever be the consequences, you have to tell the patient. If your patient is going to die, then no, you will have to tell the patient that no, I think you are going to have a painful and miserable death, although that may cause a lot of distress to the patient. So this concept is called the deontology. Most of the countries follow the principle of consequentialism because that is considered to be a more practical, considerate, soothing for patients. But you have to know the opposite principle, and this opposite principle is deontology. So this deontology is no longer practiced much though, but you have to remember this question so that you don't forget the previous concept. Now, for Indian exams, you have to know a few things about the clinical trials. It is asked in other trials also, but if you know certain things, it will be able to easily answer questions that are coming in related, because you know that nowadays all the clinical trials need to be registered. So you will have to register it. And this clinical trial registry, that is CTRI, was launched in 2007. and it was made mandatory by the Drug Consular General of India from 2009. And if it is for biomedical or health research, it is voluntary. If it is for clinical trials registered under Drugs and Cosmetics Act, then it is compulsory, mandatory. If there is any exchange of biological material, whether it is blood, plasma, CSF, semen, anything between the collaborating sites, then the EC may require appropriate memorandum of understanding. So this is important. Now, there are certain rules one should follow about record keeping. All records must be archived for a period of at least 3 years after the completion or termination of the study. Documents related to the regulatory clinical trials must be archived for 5 years after completion or termination of the study. And the EC should describe the archival and retrieval mechanisms of the SOPs, and records should be accessible for inspection by authorized representatives of the regulatory agency. So these are the ethical principles which pertain to clinical trials, because this is one area on which there has been a lot of ethical violation in the past years, in the past decade or so, or during the early part of 2000. So all the governments are particularly careful about this. So this is the protocol that is followed by the ICMR in India. So likewise, there are protocols for FDA and so on. So this part you need to understand and know. And very important also to remember are whenever there are drug trials, the serious adverse events should be reported within 24 hours of occurrence by the principal investigator to the regulatory authority, institute ethics committee, and the sponsor. Within 14 days of occurrence of serious adverse event, final report has to be submitted both by the investigator as well as the sponsor, again to the regulatory authority, institute ethics committee, and the head of the institute separately. So in case of injury or disability of the participant, the ethics committee will analyze the report and take an opinion on the causality and compensation. Expert committee appointed by the DCGI in India, they will also take the report, will analyze and on the causality, and all of this has to be done within 30 days. That is 1 month roughly. And then the DCGI will recommend on the causality and final order on the quantum of compensation within 90 days from the receipt of order of the SCE, and the sponsor to pay for the compensation to patients or relatives within 30 days from the receipt. So this is a timeline which is followed in India. Similar timeline exists for other countries as well in relation to serious adverse events occurring during a clinical trial. So now this is important to know because of its importance in the medical local domain, and the ethical principles that guide clinical trial have been largely framed keeping in mind these recommendations by the government. So it is important to know, or even if the Indian and the European systems match almost equally, in US this number of days, this 14 days becomes 7 days, this 30 days becomes 2 weeks, like also all the days are reduced. So that is one way you can try to remember it, or you go through it and see the steps. The steps are similar, that there will be first report by the principal investigator, followed by the investigator and sponsor to the regulatory authority, then to the IEC and the head of the institute, followed by ethics committee and the expert committee report to the final authority. So this is roughly one framework one has to know. It is the responsibility of the investigator to report all the serious adverse events, the sponsor or its representative who has obtained permission from the Drug Controller General within 24 hours of its occurrence. That is, the initial report should come. Thank you. I think I have touched upon the salient sections of each of those 8. So if there are any questions, I can take them.
Hello.
Yeah.
Regarding the first MCQ, regarding the methylprednisolone, the first MCQ, if you don't mind showing it again. But
I am showing.
Thank you so much. which where the correct answer, as far as I remember, was the methylprednisolone in the donor to
Yeah,
preserve the hemodynamics. Yeah.
want about to know about it?
Uh, I know that there are differences between different countries regarding the care of the organ donor, but I presume that this question, I think it's a very debatable question, and I think it's a little bit old, because I think now they are not giving methylprednisolone to everyone unless there is a cause for it, and regarding the vasopressin as well, usually the vasopressin now is reserved only for either to reduce the dose of the noradrenaline, as you mentioned, or for the diabetes insipidus. But anyway, I understand that it's a debatable, very debatable question. Could you shoot that question again?
It is debatable question, no doubt. There is no doubt. But see, the first choice or the first line is vasopressin. There should not be any doubt in that. Regarding methylprednisolone, earlier methylprednisolone was not used routinely because the study which was quoted as the corticom study, they showed no beneficial effect on graft recovery using the as with the receiving hydrocortisone. But though that after hydrocortisone, once the methylprednisolones came, then it was found to improve. So although there is some variation still, and but now the use of methylprednisolone has increased. But what is important, whenever you see such questions, you have to should adopt the method of exclusion. Like in this, the other choices, if you say myocardial ischemia is a common complication, all donors require angiography, so you have to omit it, exclude it. Next, noradrenaline is the vasopressor of choice, it increases the vascular, again you exclude it. T3 should be administered immediately in brain death to prevent vasoplay, excluded. So what remains is A. So by exclusion, you finally arrive at A, and you also know that methylprednisolone, earlier the concept was different, and now it is changing because now we have switched from hydrocortisone to methylprednisolone. So now the use is increasing. So therefore, your obvious the choice should be A. But still, I agree that there is still debate, and the variation from country to country is natural in this regard. Yeah.
Thank you.
Thank you. Any other question? You can freely ask me. If someone has a child, these are the options which are showing. Please feel free to ask any question. Even if you don't recollect now, you can ask anytime. So since there are no questions, I conclude this session now. And thank you very much.
Any idea from where to do this organ donation?
If you take my independent suggestion, then I think for this part you will have to you read from any of the hepatology textbooks. Any hepatology textbook, this part you read, because the liver donation covers most of the areas of the legislation, because that is the latest in contrast to the others. So, and if you are in India, then you follow the ISCCM update book.
Okay, sir.
That will give the ISSM update book of 2022. It came, that you can follow, or the 4C. This I will suggest that
That is ICU book.
ICU protocol book 4C.
Yeah.
So they are updated because they will give you the crisp of the understanding, but they won't give you the thing about the ethics. For the ethics, you will definitely have to read the forensic or the medicine book. Cecil, 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 there has a good portion of E attached to it. Thank you. Anyone else? Okay, thank you.